Hello, everyone. Welcome to the Kentucky REC Week of Webinars presentation on telehealth, a fad or the future. Today's presenters, Robin Kernel and Laura Wright, are both quality improvement advisors with Kentucky Regional Extension Center. I have a couple of housekeeping items. First, please keep your lines muted and enter your questions in the chat feature, and we will have time at the end. If for some reason we end up running out of time at the end, then we will have these written down and they will be able to get back to you to answer your questions individually. And then also please check the disclaimer. Our attorneys want us to make sure that you have that available. And if you have any questions, make sure to email us at kyrec@uky.edu. Next slide, please. Robin and Laura are both quality improvement and telehealth advisors with Kentucky Regional Extension Center. Robin has been a nurse for more than 25 years, and her experience covers many aspects of both inpatient and outpatient experience in rural Kentucky. And Laura has over 20 years of experience in healthcare, with the last two being with us here at the Kentucky Regional Extension Center. And she focuses on promoting interoperability, quality payment program, and telehealth. Take it away.
Thanks, Catherine. This is Robin Kernel, and so we thank Catherine for doing those introductions for us. I'm going to go ahead and let them jump to our next slide for us. So today our objectives covering telehealth include some discussion around telehealth during the pandemic, the impact that your telehealth measures could have on the quality payment program, and then where we see telehealth following the pandemic. And then as Catherine mentioned earlier, we have tried to allot some time for questions, but if for some reason we can't get to all of those, we will by all means reach out to you all following our presentation this week. Next one, thank you. So let's just get started real quickly with a brief overview of what telehealth looks like during the pandemic. So just a little backstory here, with Medicare telehealth pre-pandemic, it was pretty restrictive around several things, but in particular, you were reimbursed for virtual services offered by a healthcare provider at an authorized distance site to a patient who was located at an originating site. And those were very specific as to where that patient could be located. And then it was also limited to specific services that could be provided and the technology. And so technology was mainly just live video. In addition, there was very specific limits on what providers, what type of practitioners could provide telehealth services. And then also, if you were a provider in a federally qualified health center or a rural health clinic, you could not be a distant site, which means that patient could not be located within your clinic. You could not be a distant site, and so you could not provide services as a provider to a patient located somewhere else. So as this pandemic rolled out, or our public health emergency, however you want to refer to it, COVID-19, I think we all know it well, it hit us in March, and as we were declared this public health emergency, Medicare released waivers that essentially blew the doors wide open for telehealth services to be provided to our Medicare beneficiaries. And so it afforded several flexibilities. First of all and foremost was patients can access telehealth from home. And so now they could stay in their home, be safe, and not have to travel to the doctor's visits or whatever and do all of the screenings necessary. Ultimately, they released that originating site requirement, so now it includes homes and any other healthcare facility. We also saw the release of how you could provide that visit. And so now a lot of smartphones were being used because you could use FaceTime or Skype. You could do that audio video technology using your phone, and then whereas before we didn't have that option, and then they were just audio only visits. So then audio only visits are actually now reimbursable. So prior to that, if you used the telephone just to call and check on your patient, and there was no video technology involved, that was not a reimbursable visit, and so that was another release from one of the waivers. And then providers were now, there was actually a lift on the restriction on your provider-patient relationship. So essentially, prior to pandemic, you had to have had at least one face-to-face visit and that provider be established and using your established patient codes. And so now during this public health emergency, you do not have to have that established patient visit prior to providing a telehealth visit. And then another change that we saw was around cost sharing in regards to patient responsibility for copays and deductibles and co-insurance. And so now you can, the clinic and the practitioner has that choice to where they can reduce or waive those patient responsibilities. And then finally, they released the restrictions on what providers could provide the telehealth visit, and they opened it up to many others, including therapy and dietitians and other additional providers, again, keeping our patients and our families safe by keeping them at home. Now we're going to talk about the state legislation when it comes to Medicaid. And so I want to give a real quick call out that we know we have some of our attendees today from our state telehealth program, and that includes our state telehealth director, and we certainly appreciate them joining us. And I'll tell you, if we have questions that we can't answer, we can certainly reach out to Donna and her team at the state for any kind of clarification. So don't be afraid to ask those questions in our chat. One of the things about Medicaid for Kentucky is it was much more lax in requirements as far as to Medicaid providers as Medicare was. And then more recently, Medicaid established a payment parity law. So essentially, if you provided a service to a patient in person, but then were able to also provide that same service to the patient via telehealth, you had to be paid at the same rate. Now keep in mind that is through Medicaid. If you had contracted rates with some of the Medicare MCOs or with your private payers, they should still follow those payment parity laws, but the rates may be different. So just as a reminder, there is payment parity in Kentucky. That was prior to pandemic. That will continue through, and that will not change post-pandemic. I'd have already mentioned that Medicaid is a little less restrictive when it comes to patient location and types of services available. It was actually a little wider range than what Medicare had originally. And then also with the state, we have our state telehealth program, and they've actually updated their website. It has a completely revamped, and there's lots of work going on right now, even within the during the time of the pandemic with the state on revamping the telehealth program. And so we've added the website here. The link is not live, so we'll give you a few seconds to get that wrote down if you want. However, I wanted you to know that there's so much work going on in the background in regards to telehealth that was actually active even before the pandemic was in place. And so we have lots of teams on that. We have folks from the Kentucky REC participating in those work groups with the state, and so it's going to be well represented as far as the healthcare community when it comes to working on the state telehealth program. Next slide. So let's talk just real briefly during this public health emergency how well telehealth was adopted. Essentially, just like our title says, it was unprecedented. And so we've thrown a few statistics up here just to give you an example. So just when you think about the average increase in number of telehealth visits across providers compared to pre-COVID levels, it's 175 times more than what we saw prior. Blue Cross Blue Shield of Massachusetts released their data just for February and March, and they saw a 35,000% increase in telehealth claims. Medicare beneficiaries for in that similar time period saw over 11,000% increase in use among their Medicare beneficiaries. So when you, even CMS Administrator Seema Verna talks about how the number of remote visits seen through traditional Medicare has went from about 12,000 a week to over 1 million. And then more locally, UK ourselves has saw telehealth visits go from maybe double digits a week to hundreds weekly. We talk about patient and provider satisfaction with telehealth as well. And so overall, there's been an improved perception around telehealth in regards, folks used to be a little afraid that maybe you didn't get the same type of communication, maybe you weren't, they were just afraid of technology in general when it comes to it. But as we've seen over the last few months, patients have actually approved more of their telehealth interactions. Like we've seen a 74% increase in users reporting a high satisfaction, and they're just overwhelmingly positive about their interactions with their care providers. Some folks have went so far to say that they feel like they actually get more time with them, even though the visit may be the same 15 to 20-minute time slot. They feel like they have more one-on-one communication with them. Maybe there's not as many distractions and not as much background noise, and they're also in the comfort of their home to some extent. So, and then as far as providers, their response has been a little more warmer as well, and they view it more favorably than beforehand, and they're actually more comfortable using that technology than prior to COVID. And we've heard in the past at other presentations too that sometimes patients, they were a little leery with telehealth, but when it comes to the timeliness of a visit, maybe you went ahead and got on the telehealth visit instead of waiting maybe a 3 to 4 month time frame to get to see a specialist. So I think we are seeing more patients and more providers accept telehealth as a supplement to how they provide care to their patients. So our next slide, we want to talk about how the impact is on our quality payment program measures. And so while originally this was not something folks really considered when they started using telehealth for this time period, nobody expected this pandemic to be rolling into month 6 or 7 either. So we want to talk about how it's impacted your documentation and then, of course, some of your quality measures that are applicable. So we know with the expansion of telehealth that we saw many new codes released, G codes, point of service codes, etc. They were throwing them out. But for the most part, measure specification sheets had many telehealth codes already listed, but maybe you didn't think about that when you were selecting your quality measures for 2020 that you wanted to report, because essentially you chose those maybe late 2019, early 2020. So there are 42 telehealth eligible electronic quality measures. And so if you go back and look at your spec sheets for those quality measures that you're currently documenting against, review those codes to be sure they're included in your patient denominators. Then additionally, one of the things we wanted to add is originally there were 4 measures that we knew were not included under a telehealth or did not have telehealth measures in their spec sheets. And we also knew those 4 were some that were most widely used by clinicians as well. And so we've got those 4 up here on the screen for you. So originally, none of these 4 could be used towards your telehealth measures or could not be used towards your quality measures and provided via telehealth. Let me slow down just a little bit. But during this pandemic, they have changed that. And so you'll see on the left under that plus sign, influenza vaccination and tobacco use screening and cessation. So originally you couldn't provide these or count these under telehealth and count them in your measures. And we couldn't really understand because these are patient reportable items. If you get an influenza vaccination at your local pharmacy, you can report that to your provider and they document that. The same with tobacco screening. If you're a smoker or non-smoker, it's essentially a checkbox in your EMR. So fortunately, those have changed now, and so they can be included in your list of reported measures as provided through a telehealth service. So just keep that in mind that they've added those too. Now on the right, underneath our little red minus sign there, are 2 measures, the BMI screening and follow-up and the screening for high blood pressure and follow-up. These require clinical documentation, and while we know folks at home can use the bathroom scales to measure their weight and report that, and then also they are probably at home, or we hope you are, from a nursing perspective, monitoring your blood pressures at home, that you could potentially report those at some point. But currently, those are not considered applicable measures using a telehealth modality, so keep that in mind. That's coming. Also listed on this slide is the link that you can access for telehealth guidance on ECQMs, and that's at ECRI, so it's ECQI@healthit.gov. Okay, so the other category that can be influenced by telehealth is the improvement activities category under MIPS. So we've talked about quality category, now we're talking about improvement activities. So there are 4 improvement activities that you can use if you're providing services via telehealth. Number 1 is your chronic care and preventive care management for impaneled payments or impaneled patients. It's only listed number 1 just because it's number 1 on the slide. If you're providing your annual wellness visits to your patients, that is considered your preventive care management under your impaneled patient list, and so you can use this particular measure as an improvement activity. Secondly, telehealth services that expand practice access. So if you have taken telehealth services into your practice, and maybe you've expanded your hours. So instead of closing at 5, now you're providing telehealth services till 7, or maybe you're using them on the weekends. You can potentially use this as an improvement activity. The third one is a very commonly used one regardless of telehealth, and this is essentially those folks who have, or those providers who have access to the patient's medical record after hours. So if you get phone calls or if you do telehealth visits after hours, but you can access the patient's EMR and you can document in the EMR that you saw this patient after hours or at some other time, then that's documentation that you can use towards meeting this improvement activity. And then finally, we have COVID-19 clinical trials, and so this was added mid-year, and of course it's around COVID-19, and if you're using some of the treatment protocols for your COVID-positive patients, then you can use this improvement activity. Now, keep in mind a couple of things. Each all have their own weighting. That's what they are, and so if you're familiar with the QPP program, you understand the weighting within improvement activities. And if you're not, we're talking about QPP later in the week. But we also encourage you, if you think you want to use one of these activities, to go and look at the validation requirements for the particular activity and see what's required for your documentation. Improvement activities have to be used for at least 90 days and at least 50% of your providers using that same improvement activity. But each activity has its own requirements for documentation, so you want to check those out just to make sure that you have that in case of an audit. Next slide. So now I'm going to turn our presentation over to my colleague Laura, and she's going to take us through the end of our presentation today.
All right, thank you so much, Robin. So we all know, or let's be honest at this point, we quite frankly hope that eventually the pandemic will be over and this public health emergency period will be allowed to expire. So we wanted to discuss a few considerations you should make if you want to continue offering telehealth services to your patients, or perhaps you're still considering beginning a telehealth program. There's some helpful tips in here for you as well. So once the public health emergency is over, we don't know exactly what aspects of the waivers Robin discussed earlier could stick or which will go away and revert back to the pre-COVID restrictions. However, when it comes to those looser HIPAA requirements around software platforms, most agree that this is one area that won't remain as flexible because obviously, as we all know, patient privacy and security is of the utmost importance. So we recommend that if you went ahead and jumped into telehealth quickly and started using your apps such as FaceTime or Skype, that you will eventually need to upgrade to a more HIPAA-compliant platform. And we would recommend that you go ahead and start thinking about this now before CMS puts some sort of deadline on it later. And we actually had a couple of clients here at the REC that when deciding to start telehealth, they decided to take a slower approach when they implemented. They did their due diligence, looked at different vendors, and selected a platform that would give them that security they would need so they could sustain their program even after these flexibilities go away. So if you were just thinking about starting a program yourself, this may be the best approach for you as well. Now let's think about staffing. A lot of your staffing models, I'm sure, have looked a bit different during this time. So when you think about sustaining your telehealth services, is your model working, and can you continue serving the telehealth visits the way you have? For instance, my personal PCP office during the height of the pandemic, in order to keep down staffing in the office, actually sent all of their providers home to provide telehealth visits from home and only had one provider a day in the office. Now, obviously, as services have ramped back up, they needed to bring all of those providers back into the office, and so they're not able to continue offering telehealth visits at quite the same level as they had before. So really think about your staffing model and how you will be able to use that in the future. You'll also want to consider the broadband availability and access to technology for everyone, from your patients to your actual practice. We know that there are a lot of patients out there that either don't have the technology to support a video visit, or maybe they don't have good enough internet for telehealth. And in fact, unfortunately, we've heard of patients that have had to drive all the way to their clinic and sit in the parking lot in order to access the Wi-Fi so that they could have their telehealth visit. Or in some cases, there's been clinics that are actually walking an iPad out to those patients to sit in the parking lot and have a telehealth visit. Now, you know, we all kind of did what we could to get through a lot of these issues that came up with the pandemic, and that may have been a good option at the time, or currently still is for some of you. But when you think about long-term and sustainability, that's really not a good model. So you want to get a better idea of just how many of your patients actually have the access to continue utilizing telehealth. When it comes to scheduling, early on, you may have wanted or just needed to intersperse telehealth visits throughout your day just in order to get those patients seen. But in the long run, that isn't necessarily the most efficient model to use, because when you're doing that, you're using all of your office resources, such as your building, your utilities, your staff. If you get stuck in a room with a patient, you may have another patient sitting in that virtual waiting room waiting to be seen. So if you are scaling your program, the better strategy could be to consider bundling your telehealth appointments during a particular time of the day, or maybe at the end of the day. That way, if a provider wants to be at home where overhead is a little bit less, they could do that. Or even if it's, let's say, at the end of the day, maybe you reduce your staffing during those telehealth visits, because telehealth visits don't really utilize don't need to utilize as many resources as in-person visits. And when you think about reimbursement in the future, we may not see this payment parity continue like it is under this public health emergency. So telehealth may not be valued quite as much as it is right now. And it's not really because the work is less, but when CMS is looking at what makes up that reimbursement, then your overhead, your practice expense is probably going to be a little bit less. And you may not be able to see as much value unless you bundle and try to provide those services from home or under a reduced overhead expense. And then finally, have your frontline staff and providers really bought into the value of the program? And does your leadership also believe in the value and impact of the program? As we all know, staff and leadership buy-in can sometimes make or break an initiative, and we really want everyone to be on board with this program. Next slide. All right. So I think we all know that telehealth is not necessarily a one-size-fits-all model, and it may not work for all practices or all programs or patient populations within your practice. So when you're thinking about the best uses for telehealth, think about what is the intensity of services needed to impact your target populations. And you can start by thinking about what's necessary to diagnose and treat those populations, and is it even conducive to telehealth? Some particular best uses for telehealth include providing urgent care services. So I think we probably see this most commonly. If a patient presents with respiratory or sinus symptoms, maybe a sore throat or a rash, some of these most common acute issues can be easily diagnosed through telehealth. There has also been a lot of success in providing mental health and substance use disorder services via telehealth. And in fact, a lot of patients say that they like the anonymity that comes with it, and they don't have to worry about being seen entering or leaving an office and worrying about that stigma that's unfortunately attached sometimes. Teenagers and young adults have particularly expressed preference in participating in telehealth sessions because they are so tuned into their phones and electronic devices that it's just a way of life for them. You also have the opportunity to use telehealth for follow-up visits related to chronic conditions such as hypertension or diabetes. So if you typically have patients maybe return to the office to discuss lab results, or let's say you've updated or made a medication change for that patient, think about using telehealth to just do that follow-up visit instead of having them come back into your office. And then, unfortunately, a large number of people either delayed care on their own during this pandemic, or they were delayed due to offices being closed or having lower staffing. So you could consider using telehealth to help with that backlog and kind of get yourself caught back up. And it can also help patients feel safe, knowing that they don't have to go to the office and risk possible exposure if that is one of their concerns. Now, like I said, it's not a one-size-fits-all model, so we're going to discuss a few cases where telehealth might not be the best option or may not be possible at all. As Robin mentioned earlier, you can currently perform the Medicare wellness visits using telehealth. However, when you're thinking about the future, it's probably best to have your patients come into the office at least once a year for those physical exams. You know, get your eyes on them, do that physical exam. Next, if you receive critical lab or imaging results, most likely you're probably going ahead and contacting those patients immediately, either to go to the emergency room or make another appointment as soon as possible. So you're potentially not going to wait for a telehealth visit for that. And then also, it might be a little more challenging to manage patients with multiple complex problems using telehealth. Those may also just be better suited for the office environment. When it comes to highly sensitive matters, I've kind of actually gone back and forth on this one. There are some patients or providers that would prefer to have those discussions, let's say around a new cancer diagnosis. They'd rather have that in the office face-to-face. However, I've also heard about patients reporting that they actually appreciated receiving the news in the comfort of their own home, perhaps with family members present. So I think for this one, you probably want to treat it on a case-by-case basis and be sensitive of the patient that you're delivering the news to. You really know your patients best and know what they would prefer and what would be better for them. And then, of course, obviously, we can't have patients performing procedures on themselves, so they would need to come into your office for any procedures they may need. So to answer our question, is telehealth just a passing fad to get us through this pandemic, or is it the future? Here at the REC, we truly believe it is the future, and that future is now. So we're going to spend the next couple of slides explaining just why we feel that way. So we thought we'd share several quotes from legislators and CMS's own SEMA Verma around the future of telehealth and how we interpret their comments. First, basically, the pandemic forced us to fast-track the adoption of telehealth. And now that the genie's out of the bottle, there's no going back. We can't really put that genie back in the bottle. Next, again, CMS doesn't think it would be a good idea to force their beneficiaries back to only in-person visits. So we interpret this to mean that we expect CMS to cover a wider range of patients and services delivered via telehealth. It furthers equity for our vulnerable populations, and there's really no argument that this is critical. And then finally, SEMA Verma was asked about the payment parity that's currently in effect for telehealth visits under this public health emergency. Her comment leads us to believe that continued parity for all eligible visits is probably unlikely. However, there may be some specific cases of parity possible. And then there's also a lot of movement around telehealth in the legislative realm as well. There's really so much out there. It kind of makes my head spin when I was reading through all of these and trying to figure out exactly what bill is calling for what. But there have been several pieces of legislation proposed around reducing restrictions for telehealth and making permanent a lot of those flexibilities that have been granted during this public health emergency. So these include the first three that are listed here on the left, starting with the Home Health Agency's Proposed Rule, the Protecting Access to Post-COVID-19 Telehealth Act, and the Advancing Telehealth Beyond COVID-19 Act of 2020. CMS is also exploring whether telehealth flexibility should be extended through conducting OIG assessments. There are two concurrent reviews actually going on that are based on Medicare Parts B and C data, and the use of telehealth services in Medicare during this public health emergency. And they are also reviewing the use of telehealth to provide behavioral health services in Medicaid managed care. And finally, there is a task force on telehealth policy currently working to formalize recommendations for remote healthcare delivery nationwide. So lots and lots of work going on, and it's very exciting to think about some of these acts and what it could mean for the future of telehealth. And then additionally, there have been several proposals around assessing resources and the use of telehealth during the pandemic and determining how the quality and access to the services could be enhanced. So these are here on the right, and they include the Enhancing Preparedness Through Telehealth Act, Keep Telehealth Options Act of 2020, and then Evaluating Disparities and Outcomes of Telehealth During the COVID-19 Emergency Act of 2020. And then most recently, I'm sure a lot of you saw, actually it was just last week, President Trump signed an executive order aimed at making some of the telehealth expansions around services, staffing, and supervision that were put in place during the public health emergency permanent. The order on improving rural and telehealth access directs HHS to develop a Medicare payment model that should give rural providers flexibilities from existing Medicare rules, establish predictable financial payments, and encourage the movement into high-quality, value-based care. And it also addresses improving infrastructure in rural areas, which, as I stated earlier, is a desperate need that we have in Kentucky. And then in a statement as a response, Seema Verma actually predicted telehealth will become the modern equivalent of the house call. So more to come on all of that. And then on the heels of President Trump's executive order, CMS also released the Notice for Proposed Rulemaking around the Physician Fee Schedule and Quality Payment Program. Now here at the REC, we have been anxiously awaiting its release as we anticipated that it would have to address telehealth in some form or fashion. And while we were correct in that assumption, I have to admit personally, I was just a little disappointed that CMS didn't propose more drastic changes. Now, we did see in that previous slide, there is a lot more action going on around this, but here is a brief overview of what was in that proposed rule around telehealth. So CMS is proposing to add HCFIX codes for 22 services to the list of Medicare-covered telehealth services. And some of these services include care planning for patients with cognitive impairment and group psychotherapy, just to name a couple. They are proposing to allow the use of temporary codes that were put in place during the public health emergency to be used through the end of the calendar year the PHE expires. So for instance, let's say for some miraculous reason, the emergency is allowed to expire next month, then CMS recognizes providers can't necessarily just immediately stop using some of these temporary codes. So they would be allowed to use them through the end of 2020. Here is where I was most disappointed because CMS did not propose allowing a patient's home to serve as an originating site, but they did uphold that you can use it for the treatment of a substance use disorder or a co-occurring mental health disorder. And then CMS also proposed several updates around physiologic monitoring, or sometimes we refer to it as remote patient monitoring services. I'm not going to mention them all, but a couple of them include clarifying that RPM services are considered evaluation and management, or E&M services, and that an established patient-physician relationship will be required once again after the PHE declaration ends. Now, CMS is always asking for comments around their proposals, and I think now more than ever, if you wish to see changes around Medicare covered services for telehealth, you need to make sure your voice is heard. Please provide comments and feedback to CMS during this time, and you have 60 days to do so, and again, that was released last Monday. And in the meantime, healthcare organizations should also advocate at the local, state, and federal levels of government to sustain the use and reimbursement of telehealth beyond this public health emergency. Now, I only briefly touched on remote patient monitoring just a minute ago, but keep in mind it is another telehealth modality that is on the rise, especially since the pandemic has forced so many patients to stay at home. So it's another avenue you may want to explore as we look to the future of telehealth. But please use it wisely and for the greater good, as opposed to what's illustrated here in this comic. So thank you so much for your time and attention today, and I will now turn things back over to Catherine.
Thank you, Laura and Robin, for this really helpful webinar on telehealth, which we all know we really need during this national pandemic and the national emergency. We have a couple of questions since we still have a few minutes. One question is, are there applications or platforms not currently allowed for telehealth use?
Well, I'm still unmuted, so I'll just go ahead and jump in with the answer to that one. And yes, now we did talk about FaceTime and Skype that are acceptable. FaceTime Messenger, video chat, Google Hangouts, they are also acceptable only during this public health emergency. However, there are other third-party applications that are not. These include like Facebook Live, Twitch, TikTok, and other similar video applications that are public-facing. So remember, you should not use those to provide telehealth services.
All right, and we have another question, and we still have a couple minutes so we can take this question. You mentioned Medicare wellness exams. Can they still be performed via telephone through the end of this year?
Hey, Catherine, this is Robin. I'll take that. So, yes, right now they can. Just keep in mind that telephone visits are paid at a different rate than using some type of audio or some audio-video technology. And as we mentioned earlier in a slide, we use the term audio only because those are strictly by those telephone visits that maybe some folks still have a landline or they have a phone that doesn't provide the video option. So just keep in mind that when you're making a telehealth visit by telephone or audio only, that they are paid at a different rate. But yes, you can currently still provide those at least through the end of the pandemic and potentially through the end of the calendar year as well.